So objectives for today's didactic blitz, we're going to review principles and practices of trauma-informed care, review the socio-ecological model for understanding the impact of trauma, and identify strategies to work more effectively with survivors of trauma. According to SAMHSA's Trauma and Justice Strategic Initiative, trauma results from an event or series of events or set of circumstances that experienced by an individual is physically or emotionally harmful or threatening, and has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. Trauma-informed care is a strengths-based service delivery model that's grounded in understanding of and responsiveness to the impact of trauma. It emphasizes physical, psychological, and emotional safety for both providers and survivors, and it creates opportunities for survivors to rebuild a sense of control and empowerment. Trauma-informed care is rooted in the assumption that any child or adult could have a trauma history, and this approach should be used across medical settings with all patients, regardless of whether or not we know this history. Given the high rates of adversity in the lives of children and families across the globe, trauma-informed care really should be utilized as a universal precaution. It's important to note that trauma-informed care is not trauma-specific treatment. It is very different than treatment for trauma issues or treatment for trauma symptoms. The term care in and of itself is not treatment, and trauma-informed care does fit in all contexts. So the key elements to trauma-informed approach are what are referred to as the 4 R's in some of the literature. So that's realizing the prevalence of trauma and the impact that trauma can have. Recognizing how trauma affects all individuals involved, whether it's within a program, organization, system, and including our own workforce. Responding by putting in this knowledge into practice and to integrate knowledge about trauma into policies, procedures, and practices. Actively avoiding any type of re-traumatization of the individual. So minimizing any risk of re-traumatization or replicating prior trauma dynamics. Treatment settings and clinicians can easily accidentally recreate re-traumatizing experiences very often without being aware. And some clients themselves are not really consciously aware that they're responding to a clinical situation in a triggering kind of fashion, but yet they are. So we want to be as mindful as we can to avoid anything that might be re-traumatizing. And rebuilding a sense of control and empowerment for those survivors. Some principles of trauma-informed care: safety. So this should be physical and psychological safety throughout an organization. Environment. Trauma-informed care involves viewing trauma through an ecological and cultural lens that recognizes how context plays a significant role in how individuals perceive and process traumatic events, whether acute or chronic. It also means creating a safe and supportive physical environment and psychological environment. Trustworthiness and transparency. So decisions are made with transparency with the goal of building and maintaining trust between clinicians and clients. Peer support. Individuals with shared experience are integrated into the organization and viewed as integral to service delivery. Collaboration. So really minimizing power differences between staff and clients and amongst organizational staff. We really want to support shared decision making. Empowerment. Patients and staff are recognized, built on, and validated, including a belief in resilience and the ability to heal from trauma. Humility and responsiveness. Biases, stereotypes, whether that be on race, ethnicity, sexual orientation, age. I mean, all of these are things that we need to be recognizing and addressing. Racism very much is trauma and should be treated as such in a comprehensive trauma-informed care framework. Trauma-informed care requires a nuanced understanding of not only how trauma impacts the lives and care of patients, but the root causes behind the trauma. So some questions when we're looking at a humility and responsiveness in terms of our organization, questions that we can ask ourselves are things like, what does trauma look like in the community that you serve? Where are the community identified pain points in the delivery of healthcare? How has an organization been complicit in compounding trauma to the community? And what might racial equity look like at your organization? And how can this tie into trauma-informed care? We want to promote trauma awareness and understanding. Being trauma aware doesn't mean that you have to assume everyone has a history of trauma, but more that you anticipate the possibility across the board with any patient, from your initial contact and interactions to intake processes, screening and assessment procedures. We want to familiarize clients with trauma-informed services, and which includes informing them of trauma-related questions that might come up during the initial intake and or for future screening. Reasons for screening for trauma, providing psychoeducation about trauma and about typical normal trauma reactions, normalizing and informing them of specific trauma-specific interventions. A trauma-informed perspective views trauma-related symptoms and behaviors as an individual's best and most resilient attempt to manage, cope, and rise above his or her experience of trauma. So some individuals that means they've adapted and coped with little difficulty. They're doing fairly well. And the adaptive and coping strategies of others might have worked in the past and they're not working as well right now. But looking at it from this is the doing the best that they can, and recognizing that symptoms and behaviors are very normal responses to very abnormal situations. It really takes away some of this pathology mindset regarding some of the behaviors that we see in trauma survivors. Many survivors don't draw a connection between their mental health and substance use issues, which might make it more difficult for them to see the value of trauma-informed or trauma-specific interventions. Not every client who's experienced trauma is engaged in mental health services or sees the need for or wants any kind of trauma-specific treatment. But if individuals engage in mental health and substance use treatment without addressing the role that trauma has played in their lives, it could potentially inhibit their recovery in the long run. Trauma can disrupt a person's core assumptions and beliefs about life, the way that they organize their life and interactions with the world around them. So engaging the impact of trauma, it's important to understand the meaning that the survivor has attached to the traumatic experience and to their survival. It's not really about the events. And many events, when you talk to individuals, they would look at those events in hindsight and say, well, those weren't trauma, those weren't traumatic. And that may be because of the meaning that they've created out of them, while others would look at the same event and their meaning might be very different. So they're seeing them as a traumatic event. So this, what meaning they've made out of this and how they're processing it is much more important than the events themselves. Being trauma aware encompasses a broad awareness that traumatic experience and the impact of an individual's trauma can extend to significant others, family, first responders, medical professionals, the broader social networks, entire communities. It means viewing trauma through a socio-cultural lens. As culture influences the interpretation and meaning of traumatic events, individual beliefs regarding personal responsibility for trauma, subsequent responses, meaning and acceptability of symptoms, support, or help-seeking behaviors. So SAMHSA's treatment improvement protocol on trauma-informed care uses a social ecological model to explore trauma and its effects, and that's the diagram that you see here. The social ecological model provides a systemic framework for looking at individuals, families, and communities affected by trauma in general, highlighting the bidirectional influence that multiple contexts can have on the provision of health services to people who've experienced trauma. The focus of this model is not only on risk factors, but on protective factors that can, protect against or lessen the impact of trauma. It considers culture, developmental processes, the era in which trauma occurred, and all of that can significantly influence how a trauma is perceived and processed, and how an individual or community engages in health seeking, and the degree of accessibility, acceptability, and availability of resources. Each of the rings in this diagram represents a different system, the innermost being the interpersonal, so it embodies all the immediate, the individual and their biopsychosocial characteristics. Just outside of that, the interpersonal is their immediate relationships, family, friends, peers. Community is all of the social networks, workplaces, neighborhoods, institutions. Societal, kind of that larger state, federal policies, social norms, political ideologies. The outer ring is the period of time in history reflecting when the event occurred. And this influences, all of them influence each of the other levels represented in the circle. An example of how period in time is looking at society's attitudes and responses towards veterans homecoming across different wars throughout time, and how that homecoming environment could either become a protective or risk factor for their long-term healing. So within trauma-informed care, we are all, we're trying to build resilience. We want to help clients reestablish social connections. Part of that is ensuring the provider-client relationship is collaborative, that we're building collaboration that extends beyond our individual relationship with the client and extending into other services and across the community. We want to ensure clients have representation and opportunity to engage in development, planning, and evaluation of programs, which could support to peer support training and certification, and the availability of peer supports within the staff as another individual to engage survivors of trauma. And from a practical perspective, practitioners can use trauma-informed communication skills to increase patient comfort and reduce distress. So basic skills like listening, empathy, validation, and compassion. Recovery from trauma is a primary goal. So we want to provide hope. The characteristics of trauma and subsequent traumatic stress reactions can influence how individuals respond to their environment, relationships, interventions, and treatment services. They can shape the assumptions that the client has about the world, their future, themselves, and the breadth of these effects might be very observable or very subtle. But again, once you become aware of the significance of a traumatic event in a client's life and begin to view their presentation as adaptive, your identification and classification of their symptoms and behaviors can shift from pathology to one of resilience. So that normal reaction to an abnormal situation. So engaging in a hopeful, strengths-based stance that builds upon the belief that their response to the traumatic experience reflects creativity, self-preservation, and determination. And maintaining a hopeful outlook can be critical, but it can be hard. We have to help clients gain perspective, see small successes along the way. Obviously, you also want to always address sleep disruptions, acknowledge grief and bereavement, and at some point, if it's requested and appropriate, refer to trauma-specific treatment services. A comprehensive approach to trauma-informed care must be adopted at both the clinical and organizational levels, though. This is not something that we can just do as clinicians, because if providers or health systems attempt to implement trauma-informed care at just a clinical level without proper support at the organizational structure, or without some type of organizational culture change, the result can be uneven and often unsustainable. A narrow clinical focus also fails to recognize how non-clinical staff within our healthcare system often have significant interactions with patients that can be critical to ensuring the patients feel safe. A trauma-aware workplace also normalizes secondary trauma and supports supervision and program practices that educate all direct staff on secondary trauma, encourages the processing of trauma-related content through participation in peer-supported activities and clinical supervision, provides them with professional development opportunities to learn about and engage in effective coping strategies that can prevent and reduce effects of secondary trauma or trauma-related symptoms. In addition, organizations need to reinforce the importance of staff autonomy, choice, and sense of control. If you think about parallels between administration staff members versus staff and clients, there's often kind of a parallel philosophy and attitudes that are conveyed. These things that can mirror staff-client interactions. I guess a simple way of stating it is that if staff don't feel empowered and safe, it's unlikely that they're going to be able to create an environment that allows clients to feel empowered and safe. So part of creating a safe work environment and supporting a culture of wellness is not just encouraging good coping skills and encouraging balance between personal and professional life. It also means that organizations should be doing things that provide some wellness to their staff. So offering competitive wages, benefits, performance are all things that can be looked at as trauma-informed or trauma-informed towards their staff. Creating a safe work environment, both the physical safety, so if, whether that's security or appropriate lighting, whatever the physical safety specific things that you would need in your workplace, but psychological safety, promoting respectful interaction among staff at all levels of the organization. Establishing policies that normalize secondary trauma as an accepted and standard part of working within healthcare. We see a lot of trauma, vicarious trauma, is something that we very often are potentially susceptible to, and that is a systemic, large picture problem, not the result of an individual pathology or somehow a failure to be resilient enough. Things like instituting manageable caseloads and productivity expectations absolutely helps people to feel more safe and creates a more trauma-informed workplace. Um, letting staff or giving staff the opportunity to give input into clinical and administrative policies that affect their work experience. So that's that sense of empowerment, making sure that if there are things like vacation, health insurance, benefits that promote good health and well-being, implementing some kind of regular, consistent supervision and peer connection between staff members, and ongoing trauma-informed services training offered by the organization so that people have a good sense, not only clients who need to understand the impact of trauma, but so that all clinicians can too. So in summary, trauma-informed care is not trauma-specific treatment. It is appropriate for all settings and situations as a universal precautions approach. And while we didn't talk about this today, a trauma-informed care approach is also being utilized in some school settings, K-12 school settings, because it is absolutely appropriate to go into those settings as well, really assuming that there are things in people's past that you will never know about and that impact them in ways that they are not able to express. So we all need to tread gently and keep in mind, whatever we don't know, we just don't want to potentially re-traumatize accidentally through our own blinders being on. And trauma-informed principles should be applied to at the clinician level and the organizational level in order to actively resist any type of re-traumatization. Here's the main slides that I used. Again, a last shout out to Stephanie because I leaned a lot on her slides, and I did include her citations just so that they would be in a little package for everyone. Questions, comments?